Hills.
What's the weather like?
It was frosty this morning and it's chilly.
Are you actually having to look out the window to see how cold it is?
Yeah, yeah, so I'll gauge the temperature.
Ah, very good, very good. How's your morning been?
Interesting.
Oh, okay. Good interesting, bad interesting, how tense?
It's always good, interesting. It's always learning something, or trying to figure out why this didn't do what I expected it to do, or whatever it is.
Okay. So there's loads of questions we get asked, some of them time and time again. And one that we hear a lot of is how long do implants last? What would be your typical answer?
Oh yeah, okay. Yeah, we do get asked that a lot. And what I do is I go by the evidence-based answer. So I think some people think they're going to last a lifetime, which hopefully they will do. And that's the aim of what we do when we place the implants and why we do everything that we do in terms of the processes, the assessments, the way we place the restoration, all those aspects of it. But the long and the short of it is when you look at the evidence, there are failures. So when we talk about implants, we do need to explain to get informed consent that those failures do occur, and they occur more often in a certain group of patients than they do in others. So I'm rambling a little bit, but my simple answer would be that you're looking at a success rate of between 96 and 98% for the actual implant. That's the little bit that goes in the bone that supports the tooth over 10 to 15 years. That doesn't mean that in 10 or 15 years the implant's going to fail, but it means we get 2 or 4% of those implants that may fail. Then there are various types of failures. There's an early failure as such, where the implant doesn't get bound to the bone, so it doesn't actually what we call integrate, and therefore you can't put a tooth on top of it because it'll either exfoliate, or when we come to check the implant, it's soft and it's not solid. So we may then decide to take the implant out and have another attempt, and hopefully that one would work. And then we have the longer failures with implants, and this can be an infection in the implant that's called periimplantitis. And this is more common in patients that have existing periodontal disease where it's active. More common in patients that are diabetic and they're not controlling the diabetes very well, or patients that are significant smokers. And the evidence is interesting with smokers, but I do tend to warn patients that are smokers that there is an increased risk of problems with implants. In terms of the periodontal patients, if they're coming in with active periodontal disease, then I would suggest that they go through a course of periodontal treatment, and sometimes that can take up to about 18 months to achieve stability for the patient, which is a sensible time period before you think about placing implants. If you're placing sort of 1 or 2 implants and you're keeping some teeth remaining, there is the obvious treatment where patients may have all of their teeth extracted and implants placed immediately, which also has a high success rate. But you'd be looking at a completely failing dentition, and often those patients have periodontal disease. And is that the toilet flushing?
I think it may be.
Nice.
No.
And with those patients, again, we would put them through a course of hygiene therapy so that they have effectively a fairly decent, clean mouth before you place the implants, but also an understanding of how to maintain the implants they're going to be placed. So there's those factors. There are other sort of less prominent indicators that may increase someone's potential for a failed implant. Certainly, patients need to understand how to maintain the implants. That's highly important, and not just fit and forget. I think that's what some people sort of think sometimes. So there's a very large emphasis when we're looking after patients on their oral hygiene. It's like the haunted house now.
It is. I can hear all sorts of
Yeah,
noises of doors. So
yeah.
with the three categories that you've just mentioned, so patients with diabetes, those patients who smoke, and those patients with perio disease, would you say that's a no-no for them to have implants?
No, not at all. I think it's all about having a conversation where there's a process of what's termed informed consent. So there's an understanding. I know that there are certainly when I was being taught how to place implants, there were some implantologists that would not treat smokers, full stop. And there are still some out there today. And I think that's absolutely fine. It's not something that I behold to. I think if you go through a consent process and, excuse me, either come in or leave. I've got a cat that does this. It goes out, comes back in again, goes out. I think that there's a consent process, and possibly there may be a situation where a smoker comes in with uncontrolled diabetes and rampant perio disease. I might hesitate to suggest implants for a patient like that. So there is a clinical decision to be made, but I think it's a conversation with you and the patient. And I think that if the patient, because let's say they start smoking after you place the implants, what do you do then? You can't take the implants out.
No, we've had the opposite though as well, haven't we? We've had patients that have been smokers, and because they're investing
Yeah.
in their dentition, they've actually given up smoking.
Yes, I've had a lot of patients that have done that. So it's almost like an incentive.
Yeah.
So, there's another argument there that maybe you should be placing implants on smokers to stand to stop. But it's not all of them. Some of them have continued to smoke.
And chew chicken bones.
Chicken bones. Well, that comes on to the second part, because we talked about the success of the implants, and their high success rate. So that's what those studies sort of focused on. But there is a difference in the success of the implant, which is the fixture, the bit that goes in the bone, and the success of the tooth that goes on top. And that's actually slightly lower. So the success of the tooth, you have what we call complications, I suppose, technical complications. And the technical complications can be something like a screw loosening. So the tooth may sort of feel wobbly, it might click. And this can happen because either it wasn't fitted correctly and the occlusion was too heavy, there's some interferences, or patient's occlusion is dynamic. And what I mean by that is that their natural dentition can change, and then sort of interferences can then suddenly occur on the implant where the occlusion was originally balanced. And then the forces that are then on the implant were unpredicted, and therefore they aren't in the correct axis of the implant, so they don't go down the middle of the implant, they're offset. And that screw then starts to unwind slightly. And this is why patients need regular reviews. And we talk about that when we're talking to our patients, that they're going to need to come in and have maintenance. Again, it's not fit and forget. They need to come in and have one of the aspects is the occlusion that monitored, as well as the tissues around the implant, just like you do with teeth, to make sure that everything is healthy, that there's no bleeding on probing or inflammation or mucositis. Radiographs, if there is, just to have a look at the bone levels. So that's one small aspect. You can get chipping of the restorations themselves. You can get fracture of the screw. You can even get fracture of the implant, but it's quite rare. All these things, again, discuss with the patient at the consultation so they understand what can happen. So I think your original question, which I've forgotten slightly, was about what do we do with it? We talk about patients, about the success or the long term.
How long?
How long do they last?
Implants can last.
Yeah, well, they can last an extremely long time. And when you look at them in comparison to other options, then, they're right up there. There are other options that fit for patients, such as dentures, sometimes bridges can work.
No, there isn't.
and doing nothing, and just leaving the patient as they are. And I think, again, well, no, I don't think these are all discussed at the consultation. Often than not, these have been discussed prior to the patient actually coming to the consultation. But again, all these options need to be discussed. Again, even if you think the patient might know, they need to be discussed as part of the consent process, because they may change their mind. There are different options with implants as well. So sometimes you can put a single crown on an implant. Sometimes you can put two crowns on one implant. Sometimes you can do a bridge, and sometimes you can do implants that retain a denture. And again, you go through these options so that people understand, and you talk them through it in a simplistic manner, so it's not jargon. Because certainly when I started, I didn't sort of understand all the bits and bobs, and I have to be very mindful that although I understand them all, that I explain it in a way that I feel that somebody can understand it. And even sometimes when you think somebody can understand it, something as simple as the difference between what's termed a fixed restoration and a removable restoration, which might seem to me fairly obvious, it can confuse some people. And, you know, I've had people say, well, I don't understand the difference between what's fixed and removable. And I kind of get that in a way, because to me, fixed means fixed and removable means removable. And in simple terms, that means that if we place something that's fixed, the patient is unable to take it out of their mouth. And if we put something in there that's removable, then the patient is able to take it out of the mouth and are expected to take it out of their mouth to maintain it and clean it and then put it back in again. So that's essentially the difference. So one's like a denture and the other one's like teeth.
Teeth.
Yeah. Does that answer your question?
I think it does.
Okay.
Thank you very much.
It's a pleasure. No problem at all.
Should we go and see if there's any brass monkeys outside?
Yeah. Yeah.
Well, thank you for your time.
Pleasure, as always.
Always a pleasure, never a chore.
Yeah. Thanks very much.
Bye.
Bye.